I am Dr. Asaduzzaman. My topic is preventing complication in DRA, my strategic approach, and how to manage the complications as well. Let us see the introductions of my presentation. The distal radial approach for diagnostic coronary angiogram and percutaneous coronary intervention is being widely used and is becoming one of the preferred route for coronary procedure worldwide. Complications can occur due to technical challenges associated with small and anatomical variant radial or distal radial arteries. Physicians performing radial catheterization should be vigilant during and after procedure to overcome the procedure-related complications. And you can see here the two sites for distal radial puncture. One is the anatomical snap box and another in the interdigital spaces. Now, what complications we encountered in our clinical practices? Actually, complications related to the anatomical variants and complications related to the procedure. And what are the complications? So when we encounter the anatomical variants, these are the radial arterial loops, accessory radial artery, high origin radial artery, and subclavian loops. And the complications related to the procedures are radial artery spasm. It's a very common, but nowadays it's a bit little. Radial artery dissection is also less. Radial artery perforation and hematoma also rare. Radial artery occlusions, this is the delayed complications, and AV fistula and pseudoaneurysms. These are the delayed complications of the procedure. And look at the anatomical variants step by step. And first of all, the arterial loops. Loops are the important anatomical variant. In that case, select hydrophilic wire, PTC wire, or even stiff wire with floppy tip like Grand Slam. Roadmap sometimes may help to negotiate the wire and to prevent the entering the wire into the false track. Push the catheter as far as possible into the loop after wiring the vessel and pull the entire assembly slightly back for straightening the loop, and then advancement of the catheter across the loop become easier. You can see here in the loop, but initially I failed to cross the loop with the regular wire. Then I check it, there is a loop in the radial artery at the cubital fossa. And then I took the PTC wire, and it helps me to recross the loop very easily. With the help of, then you can see here, then it easily goes through the road maps help me to cross the lesion and then after crossing the lesion with the wire and catheter, then I gently pull back it, and then it's straight up. And then the rest of the procedure was very simple. And after the procedure, and sometimes there may be a radial loop with remnant radial artery. Sometimes it's very difficult to entering into the main tracks, but you need to help. You can see here the remnant radial artery on the right side, the just right track to the main radial artery and the brachial artery. But you can see here the wire in the remnant radial artery. Sometimes we may feel difficult in case of 360-degree complex loops. You can see here it's very difficult to cross the wire as well as the catheter. But very gentle approach, you can pull it back, then make it straighten and cross the lesion and complete the procedure. Another 360-degree loop. It's a very complex loop here. And now the accessory radial artery, a rare anatomical variant. And the caliber of accessory radial artery is small. Radial angiogram reveals the diagnosis and overcome by BET or transulnar approach, that is root switching, or sometimes may need to help of downsizing the catheter, that is port size catheter, which is not available in our country. You can see here the accessory radial artery. And sometimes accessory radial artery together with the very tortuous radial artery, you need to take the help of floppy wire, as well as by bed technique, you can cross the lesion very easily and complete the procedure as it. And this is the after procedure. And so high origin of radial artery. There's a common vascular variant in upper extremity, 8 to 20%. Caliber of high radial artery is small, like that of accessory radial artery. Radial angiograph also helps to diagnose, and downsizing the catheter and repeat dose of spasmolytic sometimes may help to overcome the problem. This is a very high origin. It's almost arising from the axillary artery. You can see here. And sometimes we may feel difficulties in crossing the subclavian loop. In that case, select hydrophilic wire, PTC guide wire, or stiff wire like radial loop. Push the catheter as it's in radial loop. This is the subclavian loops, variant subclavian loops here. And that also helps to cross the loop. But sometimes difficult to coaxial alignments of the catheter. And it's a very complex loop also here. Angiography can be done, but for further procedure, you need to switch the route. And now the complications. One is the most important complications, the radial artery spasm. The overall incidence is about 5 to 15%. Radial spasm may be local or focal, and it might be diffuse. When do you suspect of radial spasm? If patient complains of pain or feeling of resistance during passage of guide wire and or catheter. And how can you proceed in radial spasm? Mild sedation, repeat dose of spasmolytic. Affected segment should be crossed carefully with use of hydrophilic wire, PTC wire, and with the help of bed, sometimes downsizing the catheter. How should we should proceed to overcome this spasm? Radial angiogram through sheath or catheter, conscious sedation, and additional dose of spasmolytic. Most commonly, we practice pethidine 20 or 25 milligram. Use soft tip PTC wire. Negotiate the catheter by slow and corkscrew movement. Balloon-assisted tracking is the best friend to overcome. And also the downsizing catheter may needs to overcome the problem. There is a diffuse spasm. And also the severe brachial spasm as well. And another complication is that radial dissection. Don't push wire catheter at the site of resistance without addressing the radial anatomy by angiography. Orthogonal views are important for localizing the culprit lesion. Roadmaps helps to negotiate the wire and prevents entering the wire into the false tract. There is a dissection most commonly happen in accessory radial artery. And before the procedure, dissection was happened. And after crossing the dissection area, complete the procedure. And another dissection in the accessory radial artery, and it was sealed. after the procedure. And next, the devastating complication of the radial perforation. When do you suspect? When patient complaining of pain and or swelling of the forearm. Forceful manipulation of the guide wire and catheter may be the culprit. And what should be the next step? Don't remove the vascular access sheath. Select radial angiogram for early recognition of perforation. Use soft-tipped PTCA guide wire to cross the lesion very carefully. Prolonged balloon inflation or guide catheter placement over the wire to seal the perforation. A relook angiogram at the end of the procedure is mandatory. Radial artery perforation just before procedure. You can see here, there is a manipulations trying to cross the lesion. But when I feel resistant, then I took a cine, and you can see here there is a perforation of the radial artery. And then I cross the lesion and inflate the balloon for 10 to 15 minutes repeatedly and complete the procedure. Another case, just after completion of the PCI, there is another RA perforation. Just after completing the procedure, patient complained of severe pain. And I can see here there is no visible vessel as well. Only the dye is out of vessels. That is, the contrast can be seen out of the vessels. Then I took a PTCA wire and prolonged inflations of the balloon repeatedly. And then I complete the procedure and took a cine just after complete the procedure. And sometimes you need to switch the route to overcome the complications, and when to need to switch the route. Particularly the complex radial artery, complex subclavian loop, high risk coronary intervention, busy or rush center to minimize the time gap, severe access site complications. And next question is which route we need to switch. Switch the left radial, switch the femoral, or rarely you can switch the same side of ulnar artery also. There is a 360-degree loop with remnant artery. I try to cross the catheter with all maneuvers but failed. Ultimately, I need to switch the route. And another, the very complex procedure, severe left main disease. Patient develop cardiac arrest just crossing the wire in the left main, and you need to switch the route and complete the procedure with route switching, and patient was good. Sometimes in a diffuse spasm with poor caliber vessel, you need to switch the route. And now the key message, initial identification of anatomical variant by angiography to minimize the procedural complications. Don't push the wire or catheter at the site of resistance, and don't lose your patience and perseverance to avoid unusual procedure-related complication. Physicians performing transradial cardiac catheterization should be vigilant during and after procedure, and be knowledgeable and resourceful in implementing appropriate management strategy. Thank you all. Thank you for patient sharing.